Good morning, everybody, and welcome to our session on Dignity Has No Nationality, HIV and Migrant Rights. I'm Eberhard Schatz. I'm one of the coordinators of the European Harm Reduction Network Correlation, which is based here in Amsterdam, so I didn't have to travel a lot. And I would like to introduce my co-chair, Fatima. Maybe you can introduce yourself.
Thanks. Thanks, Eberhard. I'm Fatima Hassan. I'm from South Africa. I'm a former HIV/AIDS human rights lawyer and activist, and I currently still am, I suppose, but running the Open Society Foundation in South Africa.
So I think the issues we speak today are extremely relevant in regard of the policy developments we see all around the world. And we are very happy to have a great lineup of speakers today. And I would like to introduce now to you Philip Marotta from USA. Philip is a NIDA Foundation HIV prevention and substance abuse researcher at Columbia University. His research uses innovative statistical methods to assess relationships between structural determinants and HIV among vulnerable populations, including migrants and people who inject drugs. So, Philip, the floor is yours, please.
Thank you. Thank you, Bart, for that wonderful introduction. I am delighted to be here today. I'm going to talk today with you about our research examining the role of the criminal justice system as a social determinant of sexual risk among migrant and non-migrant market vendors in Kazakhstan, as well as implications from this research for human rights and HIV prevention with migrants. So I have no conflicts of interest to declare, financially or otherwise. We do have U.S. funders that funded this research and also funded my research on this project. Okay, so now just taking a moment, the setting of this presentation is in Kazakhstan. Kazakhstan is in Central Asia. Kazakhstan is the largest country in Central Asia. It is the center of a major economic trading routes from China to the west and Russia to the north. And if you take note, to the south of Kazakhstan, we have the countries that house the migrants that are going to be studied in this and presented in this presentation: Uzbekistan, Kyrgyzstan, and Tajikistan. The setting of this study is in Almaty, which is the former capital of Kazakhstan. Okay, now just a little bit of background information about migrants in Kazakhstan. There are a lot of migrants in Kazakhstan. There are about more than 3.5 million migrants in Kazakhstan. It's estimated that between 300,000 and 1.5 million migrants are without documentation, required documentation in Kazakhstan. And more than 1 million labor migrants in Kazakhstan there are more than 1 million labor migrants in Kazakhstan, many of whom work in the bazaars. And a majority of the migrants are from Uzbekistan, Kyrgyzstan, and Tajikistan. Now, taking a moment to look at some of the structural factors that predict HIV among migrants, there are laws that regulate migratory flows, employment, and residency requirements, which increase the vulnerability of migrants to HIV. Now, we can think about this as fear of contact with law enforcement. Globally, there's a lot of research that links this, much less in Kazakhstan. But the fear of contact with law enforcement leads to social exclusion from HIV prevention and many, many, many other health services. Also, this kind of social exclusion leads to isolation and stress, which leads to higher rates of sexual HIV risk behaviors. And the United Nations GAP report in 2017 noted that migrants are left out of HIV prevention globally and run the risk of being left behind in the global HIV response. Okay. So now let's drill a little bit deeper and look at the legal HIV risk environment of migrants in Kazakhstan. So migrants face questioning and harassment by law enforcement officers, migration police in Kazakhstan, who are in charge of enforcing the migration laws. They also are questioned quite frequently by market officials who are in charge of regulating the economic affairs within the markets in Kazakhstan. Also, they face higher rates of arrest by migration police, incarceration, as well as deportation, very high rates of deportation. Also, legal residency status and legal work status place migrants at higher risk of being targeted by law enforcement. So really little is known, despite the fact that we know that there's higher rates of involvement in the justice system and legal system in Kazakhstan. Really little is known about how the legal system influences sexual HIV risk factors among migrants in Kazakhstan. So to address these gaps, we embarked on a study that hypothesized that questioning by market officials, questioning by migration police, arrest, incarceration, deportation, lack of work permit, and residency permit would be associated with a number of sexual risk behaviors over time. So now looking at the data that was used from this study, it's called a Silk Road Health Study. It consists of a sample of 1,342 male migrant and non-migrant market workers in Kazakhstan. Consists of male external migrants from Kyrgyzstan, Uzbekistan, Tajikistan, and internal migrants. And we also had a comparison group in this study. Today I will be presenting findings from the migrants in this study, the external and internal migrants in this study. We recruited them using respondent-driven sampling, which is an innovative method to reach hard-to-reach populations. The parent study included a constellation of different factors: criminal justice involvement, migration patterns, HIV sexual risk behaviors, mobility, infections with HIV, chlamydia, gonorrhea, and demographic characteristics. So now let's look at the study setting for a moment. The study setting for this study was the Baraholka Marketplace. It consists of 28 bazaars. It employs 30,000 employees. There's estimated annual sales, according to the World Bank, of about $1.7 billion from the marketplace. Here's are some photos. Okay, so just briefly, very briefly, the statistical analysis for this study included regressions using multi-level random effects to account for the longitudinal nature of the data. We used multiple imputation to account for missing data, which we had throughout each of the assessment points. We assessed the participants at baseline, 3 months, 6 months, and at 12 months. Covariates in the regression models that we used included age, hours worked in the marketplace, whether or not the participants lived with children, and employment status in the market. We stratified by migration status to get a sense of particularly how this would impact external and internal migrants. Okay, now we're going to look at some of our parameter estimates. I don't have time to present a lot of the descriptive findings from this, so I'm just going to kind of zoom to the richest part of the data, which is the parameter estimates that we got from this study. So these are the whole table, and now I'm just going to show you the significant findings. The significant findings from this study were extremely interesting. Most notably, the odds of engaging in transactional sex among internal migrants who were questioned by market officials was nearly 3 times the odds of engaging in transactional sex among internal migrants who were not questioned by market officials. We can see that similarly for sex under the influence of drugs, the odds of engaging in sex under the influence of drugs for participants who were questioned by market officials was over 2.5 times the odds of engaging in sex under the influence of drugs for those who were not questioned by market officials. Most notably, some of these findings with the highest parameter estimates, we can look at migration police and engaging in transactional sex, where the odds of engaging in transactional sex was more than 3.5 times the odds of engaging in transactional sex for those who were not questioned by migration police. Really most startling was for incarceration. The parameter estimates for incarceration, I'll just show you the highest, talk about the highest parameter estimates, which was participants who were incarcerated had an odds of engaging in transactional sex that was about 7.557, which is very, very high. Similarly, for external migrants, the magnitude of our effects were not quite as high. However, we did find a lot of significant results. So for participants across the board, we're not showing here sex with more than one partner because none of those findings were significant, so that's worth noting. Also here, I'm not showing findings for deportation, residency status, or permit. Those results were also not significant. So what this is showing is that criminalization through engagement with law enforcement and engagement in the justice system seems to be what is driving sexual risk. So for what we found was that for sex under the influence of drugs and condomless sex while traveling, the odds was more than 2 times the odds for those who were questioned by migration police compared to those who were not. Similarly, for arrest, the odds were over twice the odds for those who were arrested compared to those who were not. And incarceration, the odds were more than 3 times the odds for those who were incarcerated for sex under the influence of drugs. So let's just kind of, to summarize some of this, the criminalization of migration status in Kazakhstan, similar to what is being found around the world right now, is associated with sexual risk behaviors. And the largest magnitude of effects, which is what we're also seeing in other studies, is that it's for incarceration and arrest, really is where we're seeing the highest rates. But they were significant also for engagement with police. So how can we think about this for implications for human rights? Well, there is evidence around the world, some limited evidence, that collaboration with law enforcement and training law enforcement and law enforcement education programs can improve the kind of qualitatively the encounters that between law enforcement and key affected groups. This has not been tried before with migrants, and I think these findings raise some questions around potentially having that discussion and what that might look like. Also, Kazakhstan currently does not have a non-discrimination law framework, a framework of non-discrimination that protects the human rights specifically of migrants. So potentially we should be thinking about this. Also, we really should be doing more to guarantee access to HIV prevention, substance abuse, and other health services. And really, among all of this, throughout all of this discussion, we must be elevating, internal and external migrants to greater positions of civil society leadership to kind of counter the stigma and social exclusion that's produced through policing and engagement with the justice system. So I would like to thank the participants of this study for giving us such rich data, and the Global Health Research Center of Central Asia, the director, Dr. Obasel, the Social Intervention Group, the International AIDS Society for giving me the opportunity to deliver this presentation, the National Institute of Drug Abuse for funding this research, and the National Institute of Mental Health. Thank you very much.
Thank you very much, Philip. I think that was an excellent start of our session. We decided to have questions and discussion at the end of the session, so every speaker has 10 to 15 minutes. We have 15 or 20 minutes left for discussion. So our next speaker, I would like to invite Bronwyn McBride from Canada. She finalized her Master of Public Health and is a doctoral student in interdisciplinary studies at the University of British Columbia. Her doctoral research with the Gender and Sexual Health Initiative aims to investigate the impacts of criminalization on the health and the rights of migrants and immigrant sex workers in the metro of Vancouver. Bronwyn.
Thank you. Hi, everyone. I'm honored to present research from the Gender and Sexual Health Initiative. It focuses on how criminalization impacts immigrant and indoor sex workers in Vancouver. I have no conflict of interest. Globally, immigrant sex workers can face barriers to health access, health inequities, discrimination, and isolation due to intersecting legal and social factors. Research by our group has found that immigrant sex workers who migrated in the past 5 years faced a 3-fold increased odds of unmet health needs relative to non-migrant sex workers. Evidence has also shown that immigrant sex workers are more likely to work in formal indoor venues, such as massage parlors. In Canada, these sites have been long-standing targets for inspections by police and immigration authorities, aiming to uncover trafficking victims and undocumented migrants subject to deportation. In 2014, new end-demand sex work legislation was passed in Canada. While these laws are complex, their key features were making the sale of sex services legal while criminalizing the purchase of sex by clients. Similarly to the previous laws, this legislation continues to criminalize third-party activities such as gaining material benefits, particularly in the context of formal indoor workspaces. So while Canadian citizens can now sell sex services legally, sex work remains criminalized for temporary residents. Sex work is also the only type of work explicitly prohibited on open work permits for foreign workers. So in this way, sex work remains criminalized for many people with immigrant status in Canada. Canadian end-demand legislation also contains anti-trafficking rhetoric. It conflates sex work, defined as the consensual exchange of sex services, with sex trafficking, defined as forced sexual labor. Since this legislation was implemented in 2014, raids on massage parlors across Canada have resulted in the arrest, detention, and deportation of immigrant sex workers. Workers have also reported these inspections as very frightening and distressing, as language interpreters are rarely available, and authorities often search for condoms and invade massage rooms. So there's community concern that enforcement of end-demand criminalization and anti-sex work immigration policies may further enhance the marginalization of immigrant sex workers. Recent qualitative research has found that immigrant managers and workers in massage parlors perceive disproportionate targeting by authorities. However, few quantitative studies have examined how criminalization impacts health and rights among immigrant sex workers. So, our objectives were to examine factors associated with worrying about workplace inspections among indoor sex workers, and to examine the independent effect of worry on workers' health access. Data for this study were drawn from an open community-based cohort known as Aisha. Aisha is built on community partnerships since 2005 and is a study of health access among street-based and indoor sex workers in Vancouver. The study includes ongoing outreach, and current and former sex workers and multilingual staff are represented across outreach, interviewer, and nursing teams. Aisha involves over 900 sex workers. Eligibility criteria include identifying as a woman, being aged 14 and up, and having exchanged sex or money in the past month. Participants are invited through day and night outreach to indoor, outdoor, and online spaces and complete semi-annual interviewer-administered questionnaires. For this research, it was restricted to participants who worked in indoor venues. This study took place from 2014 to 2017 during the implementation of end-demand legislation. Our outcome was worry about the potential economic, social, or legal consequences of facing a workplace inspection, such as losing income, facing family consequences, or being arrested. Our main independent variable was migration history. We also examined police harassment, workplace violence, and barriers to healthcare. Participants were coded as having experienced barriers to healthcare if they responded yes to any of a list of barriers, including limited clinic hours, language or health coverage barriers, privacy concerns, low acceptability of services, or poor treatment by health professionals. We conducted bivariate and multivariable logistic regression with generalized estimating equations to account for repeated measures on the same participant. Over the 2.5-year study, about 24% of participants had experienced a workplace inspection. We also looked briefly at rates of workplace inspections before and after end-demand legislation and found no differences. However, over half of participants reported worry about workplace inspections. Among them, 66% reported worry about police scaring clients, 42% worried about arrest for sex work, and about 10% about being arrested for having condoms. The median age of our sample was 37, and 28% were immigrants to Canada. Among recent immigrant participants, so those who had migrated in the past 5 years, 45% worried that a workplace inspection could result in them losing their immigration status or being deported. In our multivariable model, worry about inspections was independently associated with immigrant status, workplace violence, and work stress. Recent immigrant women and women who had faced police harassment both had an over 3-fold increased odds of worrying about workplace inspections. Based on community concerns about criminalization and barriers to health access, we also constructed a confounder model. After adjusting for key confounders, worry about inspections remained an independent predictor of facing barriers to healthcare, with an adjusted odds ratio of 1.45. So those who worried about inspections had a nearly 50% greater odds of facing barriers to healthcare. This 2.5-year study found that over half of indoor sex workers worried about workplace inspections, with recent immigrant participants disproportionately burdened. Evidence suggests that immigrant sex workers face structural barriers to accessing formal employment, economic security, and health services due to language barriers, stigma, and isolation. In this context, frightening workplace inspections and their potential consequences are an additional source of stress. The stated aim of Canadian sex work legislation is to protect vulnerable persons and communities. So, it's concerning that those among the most marginalized of sex workers may be most impacted by these objectionable enforcement efforts. Sex workers who worried about inspections had a nearly 50% increased odds of facing barriers to health care. This is alarming given that those worried about inspections were also more likely to be immigrant women who face documented health inequities. These findings suggest that there may be unintended health consequences of current policing approaches, and critically, these health consequences apply even to sex workers who have never experienced a workplace inspection. Our study found that 10% of participants feared being arrested for having condoms. Previous Aisha research has found that massage parlor owners fear that condoms may be found by inspectors and used as evidence of criminal sex work activity. This has led to massage parlors rejecting outreach services who come in to provide free sexual health supplies. So in this way, the threat of facing a workplace inspection can jeopardize sex workers' access to HIV prevention. There's significant evidence that supportive indoor venues can offer health and safety protections for sex workers, which may be particularly salient for recent immigrant women facing structural marginalization. Thus, there's serious concern that targeted inspections of indoor venues may undermine the protective effects of these work environments. This study illustrates the harms of criminalization on indoor sex workers' health. Our findings contrast against the stated health and safety objectives of Canadian sex work legislation and add to research calling to remove the legal barriers which restrict safer indoor sex work venues. Global institutions such as UNAIDS and Amnesty International have called for the complete decriminalization of sex work to promote workers' access to supportive indoor venues, and Canadian legislation should recognize these recommendations. Policy bodies should acknowledge the unacceptable gap between enforcement practices aimed at sex workers' well-being and their actual effects. There should be a shift towards ending the targeted policing of formal indoor sex work venues and decriminalizing the operation of these spaces. Finally, there should be a shift towards labor and regulatory frameworks which support the health and rights of both immigrant and Canadian-born sex workers and which clearly distinguish between sex work and trafficking. I'd like to gratefully acknowledge all of the Aisha participants, our outreach team, and our community partners for their immense contributions to this research. Thank you.
Thank you very much again, Bronwyn. It was really an interesting presentation once again, and we hopefully have the opportunity to discuss some of your findings afterwards. Our next speaker is also from the United States of America. It is Beatriz Zuru Maldonado, and she received her bachelor's in psychology from the University of Puerto Rico. Then she received her master's in clinical psychology from the University of Texas in El Paso. She is currently in a second-year doctoral student of the counseling psychology program at the Lehigh University. The floor is yours.
Thank you. Good morning, and thank you all for coming to this session. In today's session, I will be talking about the impact of immigration law concerns on immigrants' utilization of healthcare and HIV testing. I became interested in this topic because of the current political climate in the United States, which is characterized by rapid and recurrent changes in U.S. immigration laws, and how it's been impacting immigrants' physical and mental health, as well as HIV testing and access to healthcare. And there are no conflicts of interest to report. Currently, there are many immigrants that live in the United States, but Latino immigrants represent 57.5 million Latinos in the U.S., and they represent 17.6% of the U.S. population. This percentage is expected to increase by 24% by the year 2065. 43.7 million immigrants live in the United States, and 46.9% are coming from Latin America. And 27% of these immigrants are coming from Mexico. Hispanic immigrants are disproportionately impacted by health disparities in access to healthcare services as well as HIV testing. They face more difficulty accessing health services, they underutilize routine medical services, which are associated with poor health outcomes, such as having longer stays in hospitals, having more acute health crises, and high mortality rates. In terms of HIV testing, Latino immigrants have the highest rate of HIV infection in comparison to any ethnic minority. And they are also 3 times more likely to receive a late HIV positive diagnosis in comparison to non-Latino immigrants. Previous research has also found a number of factors that act as barriers to accessing healthcare and HIV testing. They lack access to bilingual healthcare services. They have low health literacy. They lack familiarity within the U.S. healthcare system. And they have limited knowledge of available health services, including HIV services. They fear being deported. They have perceived HIV stigma, and they experience many discrimination. In terms of gap in prior research, few past research had documented barriers to healthcare access among Latinos, but a gap in research is the lack of studies focusing on the impact of immigration-related concerns on healthcare access and HIV testing. The few studies that exist have focused studying behavioral changes before and after a particular immigration law has been put into effect. Therefore, there is a lack of studies that assess the potential effect of immigration laws and policies at the individual and psychological level. Our research team developed an immigration law concern scale composed of 3 different factors. The first is concern with public charge designation, which is defined as immigrants' belief that using publicly funded healthcare can jeopardize their own or their loved ones' immigration expectations. The concerns with confidentiality of health information is defined as immigrants' belief that their medical information is shared with immigration officials. And our third factor is HIV as a disfavored disease. This is defined as beliefs about the relevance of HIV in immigration judgments and beliefs, that healthcare providers will report immigrants who seek HIV testing or are diagnosed with HIV. So the present study wanted to test whether the immigration law concerns scale factors are significantly associated with the utilization of healthcare services and HIV testing. We administered cross-sectional surveys to 339 Latino immigrants recruited from a variety of settings in the year of 2015. And they were recruited in North Carolina and Virginia. The inclusion criteria: participants had to be 18 years of age or older, had to engage in sexual risk behavior in the past 12 months. And by sexual risk behavior, I mean unprotected sex. They were unknown about their HIV status, and they had to live in the U.S. for the past 6 months. The recruitment was due through Spanish radio ads and referrals from a different network of community-based organizations. The survey we administered through small groups in different community-based organizations, clinics, as well as community centers. We used the audio computer-assisted self-interview, also known as ACASI, and this program, participants were able to use headphones and listen to the items, and then they would just answer using a keyboard. This was to protect their confidentiality. Here's a table representing the demographic characteristics of the sample. So again, the sample was 339 Latinos. Around 50% of them were undocumented. As you can see, the majority of the sample was female. They had also earned more than 6th grade, but did not finish high school. And their marital status, most of them were in a stable relationship. So they were not married, but they were living with their partners. And then their monthly income level was around from between $1,000 to almost $2,000. So here's a list of the variables that we use for our statistical analysis. And also you have to the left the name of the construct, the measure, a sample item, as well as our Cronbach alphas. And I just want to distinguish between the first construct, named fear of accessing services due to immigration status. So again, this is defined as the perceived likelihood of being deported, of deportation of undocumented immigrants. This is different than public charge designation, which are the beliefs that using healthcare services can make one or a loved one ineligible for adjustment of immigration status. So for our hypothesis and approach to analysis, we had 3 hypotheses. So we hypothesized that immigration law concerns will be significantly associated with fear of seeking healthcare services due to their immigration status. Our second hypothesis is that immigration law concerns will be significantly associated with general barriers to accessing healthcare services. And our third hypothesis is that immigration law concerns will be significantly associated with yearly HIV testing. We conducted 3 regression analyses, 2 linear regressions and 1 logistic regression, and we used the immigration law concerns scale factors as independent variables, and they were entered using a stepwise procedure. So the results for our first hypothesis, we found that concern with public charge designation was the only factor that was significantly associated with fear of seeking healthcare services due to immigration status. So this factor alone predicted 5% of the variance in seeking healthcare services due to immigration status. And then the result for our second hypothesis, we found that again, concern with public charge was the only factor that significantly predicted association with barriers to accessing healthcare services. And this factor alone predicted 2% of the variance in barriers to accessing healthcare services. In our third hypothesis, we found that, again, concern with public charge designation was significantly associated with yearly testing, HIV testing, and this factor alone predicted 7% of the variance in HIV testing. And for discussion and limitations, our results point to the influence of perceived immigration laws and policies on access to healthcare services and HIV testing. Results from this study can help inform policymakers and healthcare providers on the potential immigration law-related concerns that the Latino immigration population have and that are at risk of contracting HIV. Our findings have implications for both educational and policy advocacy to be able to reduce the negative effect that immigration-restricted environments may have on the public health of immigrants. Additionally, our findings have implications for the enhancement of efforts to increase HIV testing among Latino immigrants. Our discussion and our results should be taken in light of our limitations of our study. So our study, our research method consisted of cross-sectional surveys, which may limit causal inferences of our results. And also our sample was predominantly female, who reported being in a monogamous relationship, which may limit generalizability to other populations. Given these limitations, future research should be geared towards improving the measurement of laws and the policies at the individual level. Future research should also include replication of our findings with populations in other areas of the world who are also experiencing restrictive immigration law and policies, especially with men, especially with people who are displaced and refugee populations. Such information may be useful in developing future laws, policies, and intervention. So I want to thank my advisor, my colleagues at the University of Wisconsin, as well as the support from my research team from the University of Lehigh. Thank you.
Okay, thank you very much, Beatrice, for this really excellent presentation. Our next speaker is Dr. Youssef Azad, United Kingdom. He's director of the strategy at the National AIDS Trust in the UK, and the National AIDS Trust is UK's HIV policy and campaigning charity. The floor is yours.
Thank you, Eberhard, and good morning. My subject is ensuring access to primary care for undocumented migrants in England in the face of repeated attempts by the United Kingdom government to restrict that access by introducing charging for that element of healthcare. Here's my disclosure of interests. And by way of overview, I'm going to give you some background on migrants and HIV in the UK, and on the NHS and charging for migrants within our National Health Service. I'm going to talk about the most recent attempt by the UK government to introduce charges in primary care in 2015 and our successful resistance to that move, the factors in that success, and then I'll draw some conclusions. Anyone working on HIV in the UK has to also work on migrant health access. And that's because migrant health is a majority issue. 55% of all people with diagnosed HIV in the UK are migrants. They were born overseas. And in this graph from Public Health England, you'll see new diagnoses over the last decade, back from 2016. In 2016, 55% again of newly diagnosed people were migrants. And going back across the years, you'll see roughly the same proportion back to 2007. What has changed over time are the countries of origin of migrants. In 2007, it was predominantly in that maroon colour, people from sub-Saharan African countries, and the constituent countries have changed over time. They're more diverse now, but the fact continues to be the case that there's a disproportionate burden of HIV on migrant populations, and I'm sure that won't come as a surprise to anyone in this room. To disaggregate further, in 2016, 55% overall of people newly diagnosed were migrants, 65% of heterosexual men and women diagnosed were migrants, and 47%, nearly half, of gay and bisexual men newly diagnosed in 2016 were migrants also. And it's also the case that many migrants who are diagnosed with HIV acquired their HIV after arrival in the UK. Here's an interesting example, another graph from Public Health England on diagnoses amongst gay and bisexual men between 2012 and 2016. And you'll see, for example, the bars for men from Eastern Africa and men from Southern Africa. Public Health England estimate about 70% acquired their HIV after arrival in the UK. So HIV and migration are profoundly linked in our country. The National Health Service, the next thing I'm going to talk about by way of background, is funded by general taxation and provides healthcare free at the point of delivery. So historically, you simply turn up to a doctor or a nurse, a hospital, and you get free healthcare. And there's a minimum, or there has been, the minimum of administration and bureaucracy. I'm going to be focusing on the NHS in England. It's slightly differently constituted across the 4 nations of the UK, the NHS. And I'm going to, as I said, talk about primary care, the network of general practice, family doctors that constitute the vast majority of doctor-patient consultations in the country, about 340 million a year. And primary care is also, as you might expect, the gatekeeper, the referrer into most hospital care. I've said that NHS care is free at the point of delivery. However, for the last 10 to 15 years, there has been creeping charging within the NHS for undocumented migrants. And by that, it's an overall term meaning, for example, people who've overstayed their visa, people who've had an asylum claim refused, unlawful entrants. And it's estimated, well, by definition, we don't know how many undocumented migrants there are in the country. There's some estimates of about 500,000. Certainly, there'll be a significant proportion with HIV. And it's certainly also, there's no right to work for undocumented migrants. The vast majority, if not all of them, cannot afford to pay for charges for healthcare. As a result of the charging regime, most secondary care, that's most hospital care, is not free for undocumented migrants. There are charges. There are some exceptions. Emergency care remains free for everybody, irrespective of residency status, and also treatment for infectious disease, including treatment for HIV. That's free for everyone. Though I'd add, HIV treatment used to be chargeable, and it's only free now for everyone as a result of a successful campaign led by National AIDS Trust. Primary care remains currently free for everybody, irrespective of your residency status. However, the government keeps on trying to change the situation and has had repeated consultations proposing that charges be introduced into the primary care setting in 2007, in 2013, in 2015. And very similar to the repeated amendments the government makes to immigration law, there's never a particular rationale or occasion for these proposals. They're simply repeated signalling to a populist base of the fact the government is hard on migrants and hard on migration. Each time there has been a consultation, and the consultation is the initial legal requirement if you want to change regulations. Each time there's a consultation, NAT and our allies have opposed the proposal for the introduction of charges in primary care, so far successfully, and I'm just going to talk about how that success has come about. And our key argument, as you might imagine, is that charges deter migrants from accessing a key setting for infectious disease and for HIV testing and diagnosis. And of course, that results in late diagnosis, increased morbidity, increased mortality, and onward transmission of HIV in the community. So that's our core argument. In 2013, in the 2013 consultation, the government in the end responded to all the submissions, and one of the reasons they then gave why they weren't going to move to introduce charges in primary care was the argument that that would increase rates of HIV and TB transmission. So when they came again to have another go at introducing charges in 2015, they thought they'd preempt our complaints and sort of head us off at the pass, as it were. So in their proposal, they said that whilst we want to charge for primary medical care treatment, the initial discussion between the doctor and the patient, that will remain free. And also any testing for infectious diseases, well, that will be free too. But really, I mean, why would you go to a GP to have a discussion about your health without any ability to access treatment at the end of it? It didn't really make any sense. And similarly, people tend not to go to primary care seeking an HIV test or indeed any specific test. People come to a GP with symptoms. They're not feeling well. And it's the GP who recommends a test as part of a differential diagnosis. So the so-called solution of the government to our concerns was no solution at all. So the 2015 consultation, which I'm going to sort of look at in a little bit more detail, how did we respond when the proposal came out? Well, it's all about galvanizing opposition and creating alliances. And one of the key groups that we had to get on board, and we did so really without much difficulty, were key associations of doctors. And doctors, of course, still have significant moral authority in relation to politicians and immense clinical expertise and evidence. We got the Association of HIV Doctors to submit a very powerful document opposing the changes, but also the big trade union of all doctors in the UK, the British Medical Association. We also work closely with Doctors of the World, who have a clinic in East London for undocumented migrants, who are able to provide statistics and case studies, both on the deterrent impact of charging for healthcare, and also on the key importance of primary care access for vulnerable communities, the vulnerable men and women who are undocumented migrants. We drafted a briefing paper and a template consultation response. In consultations to government, numbers of submissions are important. Lots of individuals and organisations want to put something in, but they don't have the capacity to start from scratch. So we produced a template consultation response they could then work on and build up, and we cascaded that through our different networks. And I'll come back to that a bit later. We engaged with the Department of Health's Equalities and Vulnerable Peoples Representatives Group. This was set up because there is a legal requirement on the Department of Health in all policy development to take account of human rights, equality and health inequalities. And we engaged with the media and with Parliament. I'll come on in more detail to some of the arguments we used a bit later. The 2015 consultation only resulted in a government response in 2017. There was a delay, there was an election actually in between. And the government noted the public health arguments that we and many others had made, especially around infectious disease and vulnerable communities, and also our arguments about the lack of cost effectiveness of the charging regime. No one can pay. You're not going to recoup any money from this process. All you're creating is a costly administrative burden on the massive primary care network. I'd call this by the government a dignified withdrawal. They still muttered about the fact they wouldn't mind trying to charge in primary care, but they basically said they had no plans to do so anytime soon. They did introduce new charging regulations in 2017, but there was no attempt to charge in the primary care setting, and there are no immediate plans from the government to move to primary care charging. So a success, again, which we're very pleased about. Finally, what are the factors in the success we've had as a sector in England, in the UK, in pushing back on attempts to roll out charging in a primary care setting? The first thing I'd point to is the quality of our surveillance data. Public Health England is the surveillance body, and it is an arm's-length government body, but it is absolutely committed to evidence-based public health and to migrant health, and both with their publicly available data, that's extremely useful, but also they're willing, we know them well, to do specific analyses of their data relating to migrants if we would find that useful. And the simple fact that we have very powerful data on the burden of HIV on migrant populations, and indeed the burden of other infectious diseases, really enables us to make the public health argument about the harm of introducing charges into a primary care setting. It's also been useful, actually, this data, in terms of rebutting the right-wing media claim that people are coming into the country to access our healthcare system for free. The Public Health England data show that the average length of time between arrival in the UK and getting an HIV diagnosis is 5 years, which doesn't sound like people trying to access HIV treatment as soon as they get off the plane. So we could rebut that argument, and actually, in the end, the right-wing media stopped using it because we had the data to show it wasn't true. Similarly, the Public Health England data shows where people are diagnosed HIV positive. So we have data that shows an increasing rate of diagnosis of HIV in a primary care setting and an elevated rate of diagnosis of HIV amongst migrants in a primary care setting. Most recent year for which we have data, 13% of black African men and women were diagnosed in primary care. And this proportion is increasing, as I said, and it's in the context of primary care still underperforming on HIV testing and diagnosis. So we could show the importance of the primary care setting, the CD4 count, and I think Beatrice mentioned this just now. The CD4 count at diagnosis shows the elevated rates of late diagnosis, which of course mean extra costs for the NHS when they treat HIV. And they also, through back calculation, as I've previously shown in a graph, can show significant HIV acquisition rates in migrant communities. So surveillance data has been key to be deployed in making the arguments against charging in primary care. More generally, research data is important. Sigma Research in 2014 did an Africa Health and Sex survey, and they showed that the preferred setting for African men and women, migrants in the UK, for HIV testing is primary care. Another good example and another good argument we could put forward. And weighted representative samples in Positive Voices and Stigma Index of people living with HIV give us powerful evidence of stigma and fear of immigration enforcement by migrants in healthcare settings. Coalition building I've already mentioned. For about the last 10 to 15 years, there's been an entitlement working group consisting of NGOs from the health, migrant and human rights sectors, plus many individuals. We strategize amongst ourselves around any attempts to increase charging in healthcare settings. We create resources such as the template consultation response I've talked about. We cascade information and documents through our networks, and it's been a very effective alliance. Similarly, doctors, as I've said, are immensely powerful. They not only have ethical and clinical concerns around charging, but they just don't want to be immigration officials. There's a great organisation called Docs Not Cops in the UK, which sums it up, really. And we have support from Parliament as well. After the charging regs came into force in 2017, we got a debate in the House of Lords, and that forced the government to set up a formal review of the charging regulations and their impact on vulnerable communities and public health, which is still going on. And our policy arguments I've talked about, the public health treatment as prevention argument, other infectious diseases, the costs of late diagnosis and onward transmission, and the simple unnecessary costs of administering a charging system in primary care, as well, last but not least, human rights and equality obligations. Any hope for the future? We've talked about the hostile environment around migrants, and it is very difficult, but we have had success, as I've shown. The one thing I would say is there's been a scandal recently which has resulted in the UK in the resignation of our Home Secretary, when migrants from the Caribbean who arrived in the 50s and 60s suddenly found themselves at the wrong end of this sort of hostile environment. There's now a review to possibly change some of the hostility. So in terms of conclusion, my final slide, policy success can be about stopping bad things happening. We mustn't be complacent. I'm sure there'll be another attempt to charge in primary care. We must use this current Windrush scandal to try and push against the hostile environment for migrants. And the government always says that the UK is too generous compared with other countries and we should level down. I hope, though I don't want to overclaim for our system, to the extent we do better than other countries, it can encourage elsewhere some levelling up. Thank you very much.
Thank you very much, Josef. That was an excellent presentation and giving us an example of successfully influencing policy by evidence. Our last not least speaker is Anna-Mia Ekström from Sweden. She is a clinical professor in infection disease epidemiology focusing on HIV, and she's a group leader for research group Global Health, HIV and SRHR at the Department of Public Health Science. The floor is yours.
Thank you for inviting me to talk a little bit on migrants' HIV and TB screening in Sweden, which is up in the very north of Europe, for those of you who are not geographically oriented. Sweden has a small population of only 10 million people, but about 20% are first-generation immigrants, and more than 30% have at least one foreign-born parent. Sweden was the country during 2015, during the large migrant waves to Europe. Sweden was the second country after Germany to receive the highest absolute number of migrants in 1 year, and the country which received the highest number of migrants in proportional to its population. And this created a lot of political debate, and as of recently, almost all political parties have sort of flipped and changed their standpoint on migration, from the majority of them being fairly positive to migration to the majority saying that we must become much stricter on migration. And this has been as a result of fear. A nationalistic party has gained a lot of support in Sweden, and other political parties are afraid of losing votes for an upcoming election in the fall. So unfortunately, we see a much stricter policy on migration. But at the asylum seeking peak in 2015 had a lot of young people coming, and it's been taking a long time for us to catch up in terms of health screening, which I will talk about soon. We see that the majority come from Syria, Iraq, Somalia, Eritrea, and Afghanistan. A lot of them are very young. More than 40% were in 2015 and 16 were under 18 years of age, and many of them were unaccompanied and came alone. A history of sexual abuse and use, both during the flight and also in Sweden, is common, and we also know that poor mental health as a result of trauma is very common. In Sweden, as you just saw the picture from the UK, we have an even larger proportion of new infections, HIV infections, that are among migrants. More than 80% are born abroad, and most of these have acquired the infection abroad. Most are late testers. They come when they're symptomatic. Very few are actually caught in our health screening examinations. Same story with tuberculosis. The great majority have been infected before coming to Sweden. We also know that migrants run a double risk. Around a double risk, it's hard to know exactly to get infected with HIV within Sweden. The health examination for asylum seekers is free and voluntary, and it's primarily aimed to identify infectious diseases at an early stage. It's offered to asylum seekers, primary asylum seekers, but there's no system to really catch family migrants who follow sort of once the primary caretaker has received asylum. HIV testing is offered to all, TB testing only for those who come from endemic countries. And adult asylum seekers are entitled to care that can't be postponed, which is emergency care, but also TB and HIV treatment, antenatal care, abortion, and contraceptive counseling. There's actually a low uptake of this health screening. Less than 40% of asylum seekers received a health examination in 2015, and a very low proportion in the capital city of Stockholm. This has gone up since then. But we still see a very low attendance among children, around less than 30%, yet any sort of health examination. Especially this is a problem for children under 7 who don't attend school and really have poor access to care. We see that I work as an HIV clinician every week and meet lots of migrants with HIV. And a lot of my time is spent in writing certificates for the Migration Board to try to convince the migration authorities to permit this person to stay in Sweden due to the need for HIV treatment and lots of other social and mental issues. But this is not a reason to receive residence permit. And what we see is that about half of those who are to be deported and denied asylum actually stay on in Sweden and go into hiding. And this is, of course, very problematic in terms of accessing health care and also increases your risk of sexual abuse and your vulnerability to all sorts of substance abuse, mental health issues, and HIV infection. Many lived in very, very crowded settings. Some of my patients share the room with 10 other people. They keep their HIV drugs in a suitcase that they need to try to bring into the bathroom every time to not be seen by their sort of neighbors and roommates that they're taking HIV drugs, because it's so stigmatizing. Many have experienced that when their landlords have found out they're HIV positive, their things are thrown out in the street and they're homeless. So stigma is still a major issue, especially among migrants living with HIV in Sweden. The information on sexual and reproductive health and rights that is available, it is available in different languages, but our studies, our preliminary qualitative studies, show that it is not targeted to what really people want to know and what they need. Some need very basic information. Since we have so many young people who came to Sweden, for example, from Syria, many of them have lost a lot of years in school and they haven't received sex education at all at home or any really education about the body. So some may not even know why you menstruate, how you become pregnant, etc. And some of the information that we see has been sort of directly translated from information aimed for Swedish youth who know a lot about their bodies, sexuality, HBTQ issues, etc. So the information we see is not really adjusted to all of the groups in need. The qualitative research I'm going to present has been performed by my colleagues, both at the TB in the team and the HIV team, and at the Stockholm County Council. It's been performed in two parts where we interviewed actors, health providers, and asylum seekers on their views on health examination, HIV and TB screening. The actors' views included, they saw this as a good opportunity to introduce migrants to the Swedish health system and also for early diagnosis and treatment. And the views were divided whether the screening should be mandatory or voluntary given the low uptake. They saw a lot of challenges in terms of not reaching out to those in need, and especially the system of calling people for visits has been initially all the letters were in Swedish and some were illiterate. Nobody spoke Swedish pretty much, and you had to find somebody to translate for you. And oftentimes, especially in Stockholm and in the larger cities, most live in private accommodation and they move around all the time. So addresses were lost, referrals were lost. The system wasn't actually, Sweden was was sort of in shock with this large migration wave, and the system wasn't set up for it or prepared. We also saw some poor coordination, and follow-up and guidelines weren't really adapted. Health providers saw similar issues in terms of invitation and the long lag time between arrival and health examination. They also found that patients had expectations that they would have a complete medical checkup and be physically examined, and they weren't. They were just sort of tested for HIV and a few other infectious diseases, and many were disappointed and didn't see the purpose. The providers felt that the purpose hadn't been explained, and they also sometimes found it hard to find interpreters. Also, large staff turnover made this difficult, and they didn't feel they had the skills to really meet the migrant needs, especially in terms of mental health and sensitive issues. Asylum seekers themselves were also they didn't see the purpose of it. They felt fear that this might undermine my chances of getting a residence permit if I test positive. Obviously, they couldn't find the clinic. They didn't know how to get there. They felt that this wasn't individual-centered. Sometimes they had relatives in the room and they didn't feel they could reveal the most sensitive issues because their mother, son, or father was in the room. But they also felt that staff normally was very friendly and they treated them with respect, and they felt that this was important and affordable, free of charge. In conclusion, health examination and screening for newly arrived migrants is a good opportunity for early detection of infections, TB, and HIV infection, and also to introduce new migrants to the Swedish health system. But we have huge problems in terms of low uptake and poor coverage, which leads to very late diagnosis of HIV. Almost all are late testers and symptomatic. We don't have enough resources to focus on mental health issues, which is a big issue. Sensitive information is not really, the system isn't set up to screen for this. And mental health care is not part of what migrants are entitled to get. Only or asylum seekers aren't entitled to get, or there's uncertainty sort of what they are entitled to. And this is a big gap, obviously, which affects health-seeking behavior and access to care and prevention. So we need to know more about the needs, and the system needs to be adapted in a better way. I'll just end with this example of a cultural norms map. It comes from the World Values Survey, which is freely available on the web. It has been collecting data from over 100 countries since 1981 on social norms and values from representative population samples all over the world. And as you see, which many Swedes are not aware, Sweden is really an extremist country in the world in terms of lots of different issues related to social norms and values. In terms of emancipation, Sweden is the country where people think gender equality, HBTQ rights are incredibly important. Trust in authorities, healthcare, the healthcare system, politicians, the police, healthcare providers is extremely high as compared to the rest of the world. This is not the case among many of our migrants, obviously, which we sort of fail to take into account when we offer healthcare services. Emancipation values are also extremely important. Individual development, girls' rights to go to school, for example, while family values, religious values are not very important in general among Swedish-born citizens. So all of these is extremely different from you see most of our migrants would come from the lower left hand corner, and we differ a lot in terms of how we see the world. And I think this is an important thing to take into account in future research, and also to make prevention and treatment more accessible. So we're actually planning to do this through a large population-based survey on migrants. And I hope to come back and present more of that data at the later occasion. I'd like to thank my colleagues for providing data information and support, and also financial support. If you need more information, or if you want to contact me, the contact details are below. Thank you for listening.
Thank you very much, Anna. And thank you for all speakers to keep nicely the time, so we have a good time to discuss and question, and Fatima will organize that.
Thank you, Eberhard. So I think, just again, a special thank you to Philip, Bronwyn, Beatrice, Yusuf, and Anna. I think 5 excellent presentations. We'll be able to take questions in sets of 3. There's 4 microphones, and we actually have about 25 minutes to have a really good discussion. I'm going to just try and summarize. I'm probably not going to do a really good job because the presentations were just, so dense and had so much information. But I think 4 key things emerging from all 5 presentations in different settings. The first, obviously, is that the global backlash on the rights of sex workers and migrants, and that intersection with HIV is quite clear in 5 very diverse settings. And I think all the presenters here today have shown why research, evidence collection, and the role of healthcare workers and doctors are probably key to build an evidence argument against this very sort of dangerous and very worrying and quite accelerated backlash. And that backlash is presenting itself in 4 key areas for all of us here at this conference that we're going to have to figure out. The first is the intersection of laws, policies, and practices, and that intersection with right-wing political governments or new administrations taking office, and what that means then for including marginalized populations such as sex workers, migrants, and migrants we're using broadly, including asylum seekers, and both sex workers who are migrants as well, in terms of accessing services, and as Yusuf suggested, a new methodology of governments to introduce a fee for basic healthcare services. The second is what that policy framework or legal framework actually means for public health and the fight against HIV/AIDS in terms of new infections. And I think the last presentation showed clearly the intersection with TB as well. And so what that means for 3 different types of services: prevention, which includes testing, early diagnosis, treatment, and also psychosocial or what we call mental support services. And so that impact then obviously contributes to what we call the dignity dilemma in this global health crisis. And that's the title of this presentation, that dignity is no nationality. So how that intersects for human rights activists with dignity or the right to dignity, advancing that universally, and access to justice services. And I think all 5 presentations particularly showed, and especially the first 3 presentations, is the intersection with law enforcement and the criminal justice system, and the role of the police, in particular, whether it's in a bazaar, whether it's in a massage parlor, and how that affects both mental health, but also affects the ability to have proper early screenings. So the first interaction, if that's with a criminal justice official, whether it's with ICE in the US or the border police in many countries, is probably going to have a severe impact on public health going forward. And then lastly, I think all the presentations really highlighted that, and I think that's been the takeaway message of this conference. And we've been having these conferences for how many years here, Bart? But that stigma is probably one of the greatest issues we still all need to address, and perhaps we underestimated that. And it's showing itself in new forms, particularly in the 5 presentations today. So how we deal with the high levels of stigma still in relation to HIV, whether you're a migrant worker living with HIV, or an undocumented asylum seeker living with HIV, or a sex worker living with HIV, or a gay person or a transgender person living with HIV. It was reflected in the opening session of the conference as well. And then in particular, I think, again, Yusuf's presentation around docs, not cops, is how do we then bring in the healthcare workers and the healthcare system, doctors and nurses and counselors to start actually quite aggressively dealing with the issue of stigma in the workplace, but also in healthcare settings. So I hope that just gave you time to actually formulate your questions. We'll now be able to take them in sets of 3, and please let us know who you are, and also let us know who you directing the question to. Thanks. Can you go to the number 1? So we have a speaker at microphone number 1, we have a speaker at microphone number 3, and then we have 2 questions at microphone number 4. So let's take number 1, number 3, and then number 4.
Yeah, thank you very much. My name is Mamadi Diakite, and I'm the Special Advisor for UNAIDS in charge of humanitarian issue. I was sitting on this table 2 days ago, having the same session on the migration with my colleagues from the UN in trying to quite really come out with a very concerted action on how we can quite really boost this agenda, taking into account that, at least from our views, the topic seems to have been left behind to some extent. So perhaps, based on what I have heard today, and hoping that, if you have been with us 2 days ago, even though it was at 7 in the morning, we could have quite really concerted, our effort for the next very important conference that is coming. But my point will be more now related to the critical human right aspect for which, some of the migrants might be quite really facing. On a different capacity, taking into account the human right function that I was also occupying, I was quite really extremely disturbed with cases of perhaps summary executions, trafficking, human trafficking, missing cases, let alone, some of those very young, underage migrant population left behind, and sometimes sexually abused even while trying to carefully reach, countries of asylum. So I'm a bit curious now, taking into account the experience on the research perspective, if you have been able to carefully gather any very specific data collection that can help us in view of the September General Assembly meeting, for which we're planning to do a very important sessions, and hoping that we can count on your voice to that effect. Thank you.
Thank you. Number 3.
Thank you. I'm Ingrid Young. I'm from the University of Edinburgh. Firstly, a comment. Thank you to the panel for such powerful presentations. My question is to Yusuf, but it I think applies to everyone. Yusuf, you really nicely showed the importance of how an independent policy organization is vital to this work, and you talked about the role of coalitions, but also the role of evidence and drawing on behavioral surveillance, or surveillance data, but also the work that Sigma Research have done. And it's been making me think about the role between policy and research. And in such a fast-moving field, the research process can take quite a long time when policy needs to respond really quickly. So I suppose my question to you is, what sort of research should we be doing that can anticipate those future needs, if given the research we do might take a year or two, in addition to talking and working closely with policy and community organizations, which I think researchers do? What are the specific research needs that perhaps we can anticipate in future to continue to work together? Thank you.
Number 4.
Hi. My name is Danielle Solomon. I'm from the Institute for Global Health at UCL. Once again, thank you so much to the entire panel. This was incredibly interesting. My question's both to Yusuf and Anna, really. It's just thinking about the fact that at the moment in Europe, anti-immigrant sentiment is, of course, being stoked largely from a political point of view. And I think both of you pointed out that most of the anti-immigrant health policies aren't evidence-based and are largely to do with the fact that they are seen to be politically favourable. And so I was wondering, what do we do from a policy point of view outside of the political sphere? How do we get populations who are currently being encouraged to express a lot of anti-immigrant sentiment and therefore are quite supportive of these policies to understand the data that we currently have and understand why the policies don't make sense and why potentially they should be changed? Thanks.
Thanks. I think we'll just take the 4th question because you are standing.
Thank you. My name is Povi Folilosson. I'm from Sweden, working with migrants in the southern part. My comments is about to Anna Mia's presentation, and I'm very sorry. It's rather a comment. It's not a question. When we were listening to a very brilliant presentation of David in the plenary today. When you don't reach out to the key population, don't blame them. I've worked in almost 20 years with key population, migrants in the southern part. I know your research is about the Stockholm City Council or County of Stockholm. And I'm sorry to hear that they are afraid. You find all the excuses to tell us why the migrants, they don't get the health checkup. When we know that we have a national strategy in Sweden saying that migration, upon coming to Sweden, within 6 months, they should be offered tests, this checkup. And when we in Sweden, we don't succeed in reaching out to them, don't say that they are afraid. Most of them, I read, they are very proud. All of them, they say yes to testing, to the health checkup. More than 90% when they are interviewed upon reaching to Sweden by the migration board. Over 90% they want to get this test. But if you ask them, we don't succeed in reaching out to them, and you start chasing them up after 2 years of living in Sweden, Don't say that they are afraid of what. So I know it's research, but I'm telling about 20 years of experience working on the field with these migrants, the same migrants you're talking about, maybe. Okay, thank you.
Thank you. And thanks to everybody who asked questions and for sharing their experiences with the room. We're going to hand over to Yusuf and then Anna and then the rest of the panel as well if they'd like to reflect on some of the questions.
Yes, thank you everyone for those questions. Just a few comments. In terms of research and data and evidence, which is absolutely key, Ingrid, I think before we even talk about what we should be asking in an anticipatory way researchers to look at, we need to make sure we're having the conversations with researchers. So there's a how to this as well. And you make me reflect on the need for, we have good relations as policy and campaigning organisations with researchers, but we don't often sit down and get some space to think a bit systematically about the gaps in research and, as it were, brainstorm ideas. And so I think one thing is simply to do it, which we're a bit haphazard about it at the moment, and some more structured thinking to preempt anti-migrant arguments in terms of research is very important. And I think we absolutely need research of the excellent kind we've already heard this morning from colleagues around the deterrent impact of anti-migrant policies on healthcare access and the impact not only on the migrants themselves but on broader public health. One of the issues around undocumented migrants is that it's quite hard to get evidence and data. The clue is in the word undocumented. And we've had a very interesting experience recently, another success actually, where we have stopped in the UK practice that's been going on for 30 years of our National Health Service sending the addresses of migrants to the immigration authorities. And they've just stopped it as a result of a campaign that we led. So that's good. But in arguing with the government kept on saying we need quantitative data to prove the deterrent impact of, loss of confidentiality. We had all this qualitative data, all this research, and they said we want the numbers. And we don't even have a denominator for undocumented migrants. It's a completely unreasonable request, and happily the Parliamentary Committee agreed with us. So data is needed. The government will always claim that they don't have enough data. I think amongst the arguments that we can use are case studies. I gave the example of the Windrush scandal, where suddenly there were faces and individuals who'd lived in the country and worked for years being charged tens of thousands of pounds for cancer treatment. So case studies are very powerful. There's a public health argument, but that's double-edged. What you don't want to keep on suggesting is that migrants are vectors for transmission. And so I think it's an argument that is both very relevant, but you need to be careful as to how you deploy it so as not to be stigmatizing. I think I'll leave it there for the moment.
Thank you. I'd like to respond to the last comment or question. And I entirely agree that the major problem, which I also tried to communicate, is not that migrants are afraid of HIV testing, but that the system is not set up really to reach out to migrants and make it accessible enough. And this is the main problem. It is entirely my experience, as you mentioned, that once migrants are offered, and anyone actually are offered an HIV test, the great majority are happy to take a test. And to learn that HIV treatment is available, free of charge, and once people are started on treatment, the great majority are extremely adherent and happy about this treatment. Sweden has reached 90, 95, 95, and since more than 80% of new cases of HIV in Sweden are born abroad, migrants who receive treatment are extremely good at taking it and happy, obviously, to receive this. So the problem is in the system, that we're not reaching out and that people aren't really accessing HIV testing the way they should. And one issue is that if you miss the screening, since the screening has a very low uptake, it is sort of hard to enter HIV testing in Sweden, because at the primary healthcare centers, almost all bookings nowadays are digital. You need a computer, and you need to be literate, you need to have, some sort of IT experience, which is difficult. We have some drop-in centers, but those are not that accessible and certainly not everywhere in the rural areas. So we have a problem with our sort of modern society somehow, and the way the system is digitalized to really reach out to we should have more mobile clinics, more drop-in clinics, it should be known that it's anonymous and that treatment is freely available and made sort of standard routine to take an HIV test whenever somebody comes to a healthcare setting. So I entirely agree with you.
Thanks. I'm just going to ask Philip, Bronwyn, and Beatrice if they want to reflect on the first question from the UNAIDS representative.
In terms of a policy point that I think is important is that sex work is often conflated with trafficking, and especially as it pertains to immigrant women worldwide. It's really important to separate these, as the conflation of sex work and trafficking is problematic both from a policy perspective as well as a lived experience perspective. And there's evidence that's shown that anti-trafficking raids in many global settings can displace sex workers to more unsafe and more isolated environments. It can undermine access to health services and can also promote sex workers' vulnerability to police abuses. So in terms of a labor rights perspective, it's important to recognize the rights of all persons to choose the work that's most appropriate for themselves. And so just that separation between sex work and trafficking, both in policy and practice and in law, is really important and kind of coincides with the rights of migrants as well.
I would also add that I think that across the board, the United Nations could do a better job ensuring that working conditions improve. So the work I do is largely around labor migrants, and the working conditions of labor migrants play a large role in discouraging, on the one hand, access to treatment hugely, and B, kind of creates negative affective states that lead to very high rates of depression, substance use, and engaging in sexual risk behaviors. And that's kind of thinking about framing the right role of law enforcement in some ways. So if we think about law enforcement should function as a really useful and essential role to any given society, and at least in the work that I've seen, that role could be in brokering better relationships between employers and workers, in the sense that the local laws, for instance, in Kazakhstan, the local laws are that employment employers have to reach a contract with their workers for them to get legal work status, and oftentimes that's avoided, and so workers have to resort to irregular work status. Then that places them at illegal work status, which then means that they're criminalized by virtue of not having a relationship with their employer. So I think a lot of it has to do with framing an enabling environment from a structural standpoint.
And based on my research, we do a lot of community-based participatory research, which means like we go into the community, we build that trust with them, and then they help us with the research. So in terms of making changes at the policy level as well as the research, I don't think there's a fast way to do this, but I really do think that we need to focus on the individual and really doing more qualitative studies and really understanding their experiences and where they're coming from, because they do have rights, and I don't think that the government are really paying attention to that. So to be able to do systematic changes, we need to start at the individual level.
Thank you. We can take 2 more questions because we still have a bit of time. Could you use that microphone? Is there a final question? And then over there, number 2. Thanks.
Hi, my name is Julia Rozanova. I'm from Yale University. Thank you very much for excellent talks. So my question is mostly to my U.S. colleague who's doing work in Kazakhstan, but others might also reflect on that. In my work, I have encountered that people in Eastern European and Central Asian settings who come for work purposes create their own sort of medicine networks where they help one another exactly for those reasons that you have outlined. And this becomes problematic because people might even have some basic medical or nursing skills, but they don't have supplies. They're not entitled to, really like give any sort of certified medical advice, and they kind of engage in self-help. But this is done in a network basis. So on the other hand, this becomes kind of sometimes the only way in which people can access healthcare because of all the reasons that have been very thoroughly addressed here. So if you have anything to comment on these phenomena and, like how that might be perhaps looked into, and if there might be some way in which those informal sort of medical self-help centers that are just like growing, by necessity might be reached out to or used or trained or in some way, perhaps grown to at least bridge those gaps. Thank you.
Well, first of all, thank you for your excellent point. I mean, I think, so my immediate reaction to that is that this is an excellent opportunity for intervention. If you think about informal economies of health-seeking behaviors, I mean, from an interventionist standpoint, I would really want to see how we could make inroads in education and using the diffusion of knowledge from informal networks. On the flip side, of course, I would like to bring more workers into formal healthcare, but if we know from so many social network interventions that health knowledge and health attitudes and willingness to seek services diffuses through social networks. And so rather than trying to eliminate that aspect, I would try to reframe it in a more positive way. I will say I have no experience working in that area in Central Asia, but as an interventionist, I would really want to do some research to see in what positive ways we could utilize that diffusion of knowledge.
Thanks. Final question.
All right. Hi. Thank you, everyone, for your presentations. My name is Sarah, and I'm from the U.S. I'm a counseling psychology student, actually, and so I was really thankful to hear, people reference mental health, because I think it's something that has been ignored, I feel like, a lot. And then also stigma, which I feel like has been talked a lot about, but I really feel like I only really hear about it, and then I look at research, but really nothing more. And so I guess as a counseling psychologist, or like a future counseling psychologist, who will see patients, but who will also do program development, who may also do research, assessment, these types of things, what are more concrete ways that, mental health practitioners can be incorporated into, decisions by the IAS or other spaces, in policy or government or NGOs, to kind of address stigma in more concrete ways instead of just talking about it.
Thanks. The volunteers on the panel to go first.
I thank you for bringing up the stigma issue. We actually I was responsible for a quality of life study among people living with HIV in Sweden in 2015, financed by the Public Health Agency. And we found that the great majority of all living with HIV in Sweden experience stigma, a lot of self-stigma, but also actually experience stigma, that they have been discriminated upon by health providers or friends, colleagues. Only a few percent had ever told anybody outside of their, the closest circle, and nobody pretty much had told their employer or anyone at work. So stigma is still a very big issue in Sweden around HIV, despite all the awareness campaigns that have been conducted. And mental health is, we have used a refugee health screener tool to screen newly arrived migrants in terms of mental health. And the preliminary results, which we're still collecting data, it seems to be a very high proportion of people reporting depression, anxiety symptoms, and trauma, PTSD symptoms. And we have a problem because this is not sort of on the list of emergency care or care that can't wait. We don't really have a system today to cater for this. And it's my experience, meeting with HIV patients, that mental health issues, social support is the main problem. Fear of being alone, fear of being abandoned, fear of being, put on the street by a landlord who discriminates on people living with HIV. So this is a huge problem, especially since many of our clients are so young and alone. They're kids almost, they're teenagers. This is difficult.
Just to say, as Anna-Mia said, I think one problem is that, while HIV treatment is free for everyone, irrespective of residency status, mental health treatment is not. So one of the problems is, even if you get free HIV treatment, HIV is so intersectional and there are so many issues around comorbidity, including mental health, you find people who do not get properly integrated care. The other thing on stigma, I'd say, is that the particular legal enforcement mechanisms, whether it's on enforced testing or on charging, that we all kind of, the raids that we've talked about, they all have a stigma message. They're all stigmatizing migrants. They're all based on assumptions, and they're sending message. As I said, these things are there to send a message to society about hostility to migrants. They're not based on evidence. So one of the things we need to be very aware of and respond to is the way all these law enforcement activities are structured stigma and reinforce alienation from healthcare.
So one of the most important findings from the study that I presented was that worry and fear about workplace inspections was enough to be linked to barriers to health access. So I think this really speaks to what you said, which is that mental health and fear, and I think especially in the realm for migrants, is something that even in the absence of direct interactions with authorities, everyone knows someone who has had a negative interaction with the authorities, and so it's enough to kind of produce a state of fear and of common stress. And so among sex workers in our study, nearly all of whom have legal status in Canada, still there's this worry about being deported or losing immigration status because of this. So I think that a broader aim is to really do a lot more work into looking at the mental health impacts of criminalization and policing and law enforcement on immigrants more generally.
Yeah, and if I just might add one thing to that. If I just might add one thing to that, we, as part of the study that I presented, we did over 80 in-depth interviews. And I didn't have time to kind of touch on that, but it told us the why of all the numbers I threw up on the board there. I mean, and it's absolutely the same psychological mechanisms that we're hearing talked about here in a totally different context, with a totally different population, with a totally different, they're in a labor marketplace, but everything we asked was out of fear of engaging with the law enforcement. I don't seek medical care. I just don't want to be visible. I don't want to be visible geographically. And so I think there's a very important geographical context. That's the legal risk environment. If anyone here is familiar with some of that literature, the legal risk environment, the notion that there is a larger structural environment that operates beyond the individual, that produces a psychological mechanism of fear that kind of connects a lot of what we're talking about.
Thank you. Our time is up. I want to thank my co-chair and the panelists again, and to all of you for joining us.